In chronic venous insufficiency, there is inadequate venous drainage, leading to chronic venous hypertension. So which three of the following factors can lead to chronic venous insufficiency? If there's a deep venous thrombosis, there will be a thrombus in one of the veins. And a thrombus is a blood clot where there should not be a blood clot. And the presence of this thrombus in the vein will occlude venous return for a period of time. Now, physiologically, this blood clot will be broken down. It won't stay there for prolonged periods of time. But for the time it is there, for the time it is present, it's going to occlude the venous return, causing a venous hypertension below the level of the blood clot, below the level of the thrombus. And this will put pressure on the valves below the level of the deep venous thrombosis, and the valves will start to fail. And once the valves fail, they don't recover efficiently or effectively because they're only small infolds of the tunica intima. So a deep venous thrombosis, although it's in a somewhat acute and transitory condition, can lead to a chronic venous hypertension and venous insufficiency syndrome. Well, cheese, of course, contains a lot of saturated fat, and there's debate about the degree to which saturated fat causes atherosclerosis and arterial disease, but we're pretty sure it doesn't cause any venous disease. Now, right ventricular failure can be a factor, because the inferior and superior vena cava drain into the right atrium. And if there's a right ventricular failure, the blood from the right atrium cannot effectively drain into the right ventricle. This means the blood dams back in the systemic veins, first in the vena cavas and then into the smaller veins. So we'll get increased pressure in the systemic veins. And over time, the increased pressure in the systemic veins can contribute towards valvular failure. And in right ventricular failure, we can also get peripheral somatic edema. Well, people who live in cold climates don't get more chronic venous insufficiency than people that live in warm climates, so that's not really going to be a factor. When it's cold, there will be a certain amount of peripheral vasoconstriction. That can affect the arterioles primarily, but it will also affect the veins as well. There can be a venoconstriction, but that's not going to lead to chronic venous insufficiency. Now, paralysis of the ankle joint is going to be a big factor because it's movement of the ankle that contracts and relaxes the calf muscles. And this is the basis of the calf muscle pump, because muscle contraction is the main mechanism that facilitates venous return. So when there's contraction of the calf muscles, that's going to squeeze the deep veins that are inside those calf muscles, greatly increasing the pressure in those veins. The anterior and posterior tibial veins, the deep veins inside the muscles, the contraction of the muscle will greatly increase the pressure, closing the valves beneath, opening the valves above, and the blood will return to the centre of the body from the periphery via this mechanism. So if the ankle joint is paralysed, or if there's fixity of the ankle joint as a result of trauma, then that greatly reduces the efficiency of the calf muscle pump, and that can lead to chronic venous insufficiency. Well, in chronic venous hypertension and chronic venous insufficiency syndrome, there's quite a few clinical features for us to look out for to help us to assess the severity of the condition in our patients. But one of these is not a feature of chronic venous hypertension. Lipodermosclerosis. Sclerosis means hardening. Lipodermo, the fat associated with the skin, the subcutaneous adipose tissue, that is embarrassed over a long period of time in chronic venous hypertension. Its viability is reduced and it fibroses and becomes hardened. And you often get the edema above that, and this is where you get the classic upside down champagne bottle leg. So the lipodermosclerosis, the edema caused by the raised pressure in the capillaries, the ankle flare caused by the dilated venules primarily, that fill up with often deoxygenated blood, giving rise to the cyanosed flaring around about the ankle. The staining of the skin, of course, is the hemosiderosis. The increased permeability of the capillaries as a result of the chronic capillary hypertension leads to the exudation of fibrinogen into the tissue spaces, which is converted into fibrin over time, and the fibrin cuffs will develop. So they're all classic features of chronic venous hypertension and venous insufficiency syndrome. The one that's not is loss of hair on the leg. And loss of hair on the leg is a classic arterial feature. So it's always worth looking at feet. If someone's got hairs on the toes, there's a fair chance that the circulation to their feet is not too bad. But the loss of hair can often start on the toes, and it can kind of go bald as it goes up the leg. And that is a classic arterial feature. So it's B that's the odd one out. Well, we can't really overstate the importance of the calf muscle pump to normal venous return physiology. So which of the following statements is not true of the calf muscle pump? So pick the one that is not true. Well, the calf muscle pump does clear blood from the venous system of the leg. As the muscles contract, it squeezes the veins and the blood is ejected upwards from the legs back towards the centre of the body from the periphery. And it does maintain blood pressure in the deep and superficial veins. Now, when the muscle contracts, that's going to greatly increase the pressure in the deep veins. So muscle contraction will increase the pressure. But when the muscle relaxes, the pressure is going to be lowered in the deep veins, allowing blood to go from the superficial veins into the deep veins. So in that sense, the contraction of the calf muscle pump keeps the pressure in the superficial veins low, which is the way it's supposed to be. Of course, if the pressure in the superficial veins becomes too high, that can lead to varicosity. Obviously, the calf muscle pump is powered by leg movements. If there's no leg movements, there's no contraction of the muscle, there's no squeezing of the veins. The efficiency of the pump does depend on the patency of veins. For example, if there's a deep venous thrombosis or other pathology or external forces which are occluding veins, then it can't work properly. That means there's essentially a traffic jam and the blood is occluded from, or the blood can't get back to the centre. There's an occlusion in the vein, preventing the free flow of blood, which is so essential in the venous system. And the efficiency of the pump does depend on the normal functioning of leg venous valves. So when the deep vein is squeezed by the muscle, the valves below have to close and the valves above have to open. Otherwise you would get regurgitation of blood back into the feet and the distal parts of the body, which of course is the opposite to the physiological direction. Now, negative pressure set up during inspiration. So when you breathe in, your diaphragm's actually going to go down. That's going to reduce the pressure in your chest, and that will suck blood back in from the abdominal vena cava into the thoracic vena cava. That is a mechanism of venous return, but it's nothing to do with the calf muscle pump. So maybe a bit of a tricky question, that one, but hopefully you are able to think through it and come to the correct answer, which is D, because that one's due to negative pressure set up during inspiration. It's not related to the calf muscle pump. Now, if the blood's not draining properly through the venous system, the blood's going to dam back, increasing the pressure of the veins. That's going to increase the pressure in the capillaries. So there's going to be an increased hydrostatic pressure in the capillaries, and that's going to force the capillaries open, and that's going to stretch the size of the gaps between the capillary cells. So there's going to be an increased gaps, there's going to be increased size gaps in between the individual vascular endothelial cells that comprise the capillary wall. Now, normally proteins are kept inside the capillary, in the intravascular compartment. But if there's increased permeability of the capillaries because of this dilation effect and the increase in the size of the gaps, then proteins can start to get out. And one of the proteins is fibrinogen. It's a very large protein. It's normally kept in, but it's squeezed out, partly because the gaps are larger and partly because the hydrostatic pressure within the capillary is greater. So we get the accumulation of fibrinogen in the tissue spaces around about the capillary. And over time, the fibrinogen will convert to fibrin. So fibrinogen is soluble, fibrin is insoluble, so the fibrinogen will precipitate out to form fibrin, and that forms long sticky strands. Now normally the red cells and the white cells are supposed to stick to that, forming a blood clot. But here there's no cells, or hopefully there's not many cells in the tissue spaces, and so the fibrin strands form cuffs around about the capillaries. And the presence of these cuffs makes it harder for nutrients and oxygen to diffuse from the blood to the tissue cells. And likewise, the cuffs make it harder for waste products such as carbon dioxide and nitrogen containing waste products to diffuse from the cells back into the blood. So that's what we mean by the fibrin cuffs. So which statements are true of fibrin cuffs? Pick two answers. So fibrin cuffs can develop in any situation where there's chronic venous insufficiency and chronic venous hypertension. They may be more common in older people, but not necessarily so, because they're not caused by age, they're caused by the chronic venous hypertension. And to say they facilitate diffusion of fibrin from the capillary into the tissue space is ridiculous. I mean, fibrin is a long sticky strand. It won't diffuse anyway, and it's not supposed to. The whole question, or that whole response, is just nonsense. Now, to say they're only found in the gaiter area is not true. They will be found in any area where there's chronic venous hypertension, causing this chronic dilatation of the capillaries. But they are more common in the gaiter area because that's where the hydrostatic pressure in the capillaries is greatest. But it's not necessarily true, because anywhere with chronic venous hypertension, the fibrin cuffs can develop. And fibrin cuffs do not support the walls of venules to keep them patent. Fibrin cuffs are pathological. A healthy human being has no fibrin cuffs whatsoever, so they don't perform a physiological function. But they do act as barriers to diffusion of nutrients and oxygen from the capillaries into the tissue fluid. And as we've said, they act as a barrier against the reabsorption or the diffusion, a barrier against the diffusion of waste products like carbon dioxide and nitrogen going in the other direction from the tissue spaces into the blood. And they do develop from fibrinogen, which is lost from the capillaries. So C and E are the correct responses there. Well, now hopefully you've got an understanding of the pathological concept of the fibrin cuff, and we'll be able to answer this question fairly readily. So, thinking about the fibrin cuff hypothesis, healed wounds are more likely to break down again due to the reduced amount of oxygen and nutrients tissue cells are receiving. So even when a wound is healing, the tissue needs to be viable. And for a tissue to be viable, it needs adequate supplies, actually adequate deliveries, if you like, of oxygen and nutrients, and adequate disposal of waste products. So, for example, to be viable, a tissue needs ongoing supplies of vitamin C. It needs ongoing supplies of amino acids to synthesize the proteins. And if the fibrin cuffs are present, there's going to be that diffusional barrier. So that means if there is a slight injury to the healed area, then there's going to be no reserve capacity for further healing to occur. And wound breakdown is more likely to develop. So healed wounds are less likely to break down again due to structural support from fibrin. That's not true because the presence of the fibrin is pathological. It doesn't have a physiological function. It's wrong that fibrin cuffs are a feature of arterial disease. They're not. They're very much a feature of venous disease. And fibrin cuffs are more likely to occur in diabetic neuropathic ulcers is wrong. There's a range of pathologies that occur in diabetes, but fibrin cuffs are not one of those pathologies. The fibrin cuffs are strongly associated with chronic venous hypertension and venous insufficiency. Now we know that there can be a venous insufficiency syndrome, but there can also be a insufficiency of lymphatic drainage. So which of the following statements are true of ulcers which have a significant lymphatic component in their etiology when there is inadequate lymphatic drainage of the tissues? So it's false to say there's an accelerated lymphatic drainage. The lymphatic drainage is reduced. So there's a reduction or a delayed lymphatic drainage. And this means that excess tissue fluids will be retained in the interstitial spaces. And it also means that large molecules which are osmotic, such as proteins, that might have escaped from the blood capillaries will also be retained in the interstitial spaces, attracting further water, giving rise to sometimes really quite gross edematous changes. So they are associated with delayed lymphatic drainage. And it's wrong to say the appearance of any ulcer will always be dry because there's an excess of fluids in the area. So the appearance of any ulcers will always be moist and weepy. So because there's an excess amount of fluid in the tissues and the wound digs down or dips down into the tissues, that fluid can simply exude into the wound, giving a moist wound. And it's true that they may be caused by surgical removal of lymph glands. So if there's surgical removal of lymph glands, you might think about excision of the axillary lymph glands after mastectomy, for example. That can result in lymphatic obstruction of the limb. And they may also be caused by blocked lymphatic vessels. So the lymphatic vessels can become blocked. In the tropics, they can be blocked by parasites. Very often in the UK, they're blocked by fibrous tissue and damage to the valves in the lymphatics that develops after cellulitis. Well, this is a fairly straightforward question. Which of the following statements about leg ulcers are incorrect? So 2 of these answers are incorrect. Well, the answers here that are incorrect are A and F. It is incorrect to say the most common form of leg ulcers are arterial in etiology because the most common form is venous. And to say that leg ulcers can occur on the arms is simply absurd because they would be arm ulcers in that case. Now, it's not to say there can't be lymphatic obstruction to the arms, there can't be inadequate venous drainage of the arms, even reduced arterial filling of the arms. So there can be circulatory deficiencies that affect the arms, that's certainly true. To see frank ulceration on the arms is uncommon, but they would be called arm pathologies rather than leg pathologies. So leg ulcers may be of mixed arterial and venous etiology, that is certainly true. Tropical ulcers may persist after a traveller has returned to the United Kingdom after a time in the tropics is true, because the bacterial infection can persist in the wound. Leg ulcers may occur in diabetes is certainly true for different reasons. And leg ulcers may be painful, especially the arterial type. Venous leg ulcers can be painful. Classically, arterial ulcers are more painful, but leg ulcers are just painful. They are wounds after all. So it is correct to say that they would be painful. Well, the UK is typical of westernised countries in this respect. So the most common form of ulcer seen in the UK and other westernised countries is And there's only one answer there. Well, we certainly see arterial ulcers, and we certainly see mixed arterial and venous ulcers. We also see malignant, rheumatic and diabetic ulcers, but venous ulcers are the most common. We see a lot of venous ulcers. Well, as we assess our patients, that helps us to diagnose the type of ulcer that we're dealing with in a particular situation. So which of the following features are characteristic of a patient with arterial leg disease? That is peripheral vascular arterial insufficiency. Now, thinking about which of the following features are characteristic in a patient with arterial leg ulcers. Loss of hair is a characteristic feature of reduced arterial perfusion. So loss of hair on the leg and foot is one feature. And the skin often seems to become thin and shiny in arterial insufficiency. Now, generalized lymphedema would indicate venous deficiency or lymphatic deficiency. Skin staining around any ulcers, this hemosiderosis due to the accumulation of hemosiderin, is a very characteristic, in fact it's a diagnostic pathognomonic venous feature. Evidence of varicosity, again, is a venous feature caused by chronic venous insufficiency. And an ankle brachial pressure index, Doppler, resting pressure index of more than 0.8. If it's more than 0.8, that would indicate that it's normal. So normally the pressure in the brachial artery and in the ankle are going to be the same. 1 to 1 would be normal. And we normally say there's a significant arterial component if the ABPI is less than 0.8. So if ABPI resting pressure index is more than 0.8, that would indicate that there is not arterial pathology. Well, given what we've just said, hopefully you can pick out the 4 correct answers which are features of a patient with venous leg ulcers and chronic venous insufficiency. So as we've said, the arterial features are loss of hair on the leg and foot and shiny skin, whereas the venous features are generalized lymphedema, skin staining with hemosiderosis. There may or may not be evidence of varicosities when there's venous leg ulcers, but the varicosities and the leg ulcers are both symptomatic of the chronic venous insufficiency syndrome. And the Doppler resting pressure index of more than 0.8 would indicate that there is not a significant arterial component. Therefore, that would be consistent with an ulcer being caused by venous insufficiency. So which of the following features are characteristic of venous leg ulcers? Thinking about the ulcers themselves, how are we going to recognise a venous leg ulcer looking at the ulcer rather than looking at the whole limb, just looking at the ulcer? Well, venous ulcers are not usually dry. That's associated with arterial ulcers. And wounds have defined cliff edges. Again, that's wrong, because the cliff edges are often associated with arterial ulcers. To say the pain is often worse at night is not really true with venous ulcers. Again, that is a characteristic feature of arterial ulcers. An edema is localized around the ulcer is also wrong, because in venous ulcers the edema is usually generalized around the whole limb. So wounds are shallow with diffuse edges. That is true of venous ulcers. Sometimes it's hard to tell where the viable skin begins and the ulcer ends. The wounds are diffuse and they're shallow. And the wounds are often in the gate area in the lower part of the leg. That's also true. So 4 of these features are characteristic of arterial leg ulcers. You have to choose 4 this time. Now, when we're assessing leg ulcers, we have to do this holistically in the context of the whole person, because the individual's overall health is going to have immense bearing on the viability of their tissues. So which of the following conditions are often associated with leg ulcers? Choose 3 answers. Now, diabetes is associated with peripheral vascular disease and diabetic ulcers. So whether it's type 1 diabetes or type 2 diabetes, that doesn't make too much difference. If it's poorly controlled, then the peripheral tissues are at risk, along with many other long-term complications of diabetes. And in sickle cell disease, the shape of the erythrocytes changes to this sort of sickle shape, so they should be rounded biconcave discs. But with the sickle-shaped cells, they tend to block up the small blood vessels. And that's associated with various pathologies, but it's associated with ulceration because the areas of tissue are not receiving their normal blood supply in sickle cell disease. Now, pernicious anemia and iron deficiency anemia. Well, anemia means a reduced oxygen carrying capacity of the blood, so we'd always want to correct these. But these aren't so directly associated with leg ulcer disease. So people with diabetes mellitus are more prone to developing leg ulcers than people without diabetes mellitus. But why is that? So choose 3 reasons why people with diabetes are more at risk of developing leg ulcers. Well, there are several aetiological factors in the development of leg ulcers that patients with diabetes mellitus are particularly prone to. Now, diabetes can lead to a peripheral neuropathy. There can be degeneration of the peripheral nerves. Now, most commonly this is a sensory neuropathy, meaning there is reduced sensation in the feet and the limbs. But there can also be a motor neuropathy as well, where the motor neurons are affected. And sometimes there's a mixed motor and sensory neuropathy, predisposing the patient to leg ulcer formation. Now, patients with diabetes are actually more likely to develop macrovascular and microvascular disease. Now, people with diabetes, especially if it's poorly controlled, are predisposed to developing atherosclerosis, this deposition of fatty cholesterol-based material, which occludes the lumen of the arteries, giving rise to ischemia. So there can be atheroma in the vessels in the limb, particularly the large arterial vessels like the femoral artery or the iliac artery, reducing the blood supply to the entire limb. But any artery, any of the large arteries in the limbs can be affected by this atherosclerosis, reducing blood supply. But then also in diabetes, there's thickening of the basement membranes in the small vessels, the arterioles, the capillaries, and the venules. And this thickening of the basement membrane means that the small vessels become inelastic. And this also compromises the blood supply, the blood flow. So it's a microvascular disease. So the blood supply can be already reduced to the small vessels as a result of macrovascular disease. But then the blood supply can be further reduced as a result of the microvascular disease, leading to ischemia of the tissues and reduced tissue viability as a consequence. Now, in diabetes, especially if the blood sugar levels are high, there's an increased risk of infection. And there's several reasons for this. If there's increased amounts of glucose in the blood, there's going to be increased amounts of glucose in the tissue fluid. And of course, the glucose is an excellent bacterial nutritional substrate for bacteria. Or to put that another way, bugs like to eat sugar. So there's a good food supply for the bacteria, resulting in good conditions for the bacteria, and they're able to proliferate. And as well as that, if the tissue fluids are high in glucose, that increases the osmolarity of the tissue fluids. And all of the white blood cells find it very hard to migrate through this sugary, hyperosmotic environment. So the white blood cells like the macrophages and the neutrophils are unable to migrate to any bacteria that might be in the tissues, meaning that they can't fight the bacteria, meaning that the bacteria are free to live and reproduce, increasing the severity of infections. So we see that patients with diabetes can suffer from ischemic ulceration or neuropathic ulceration. So which of the following features would you expect to find in a diabetic ulcer which is primarily neuropathic in etiology? Can you recognise neuropathic ulcers? Well, here we see 4 features that are characteristic of neuropathic ulcers. Now, the feet are usually warm with good pulses. In fact, the pulses are often described as full and bounding. The pulses can be pathologically full and the feet are often warm. Now, the reason for this is that left to their own devices, the arteries and the arterioles will just relax. And when they relax, they dilate. It's only when they are neurologically stimulated that they will contract. So if there is de-innervation as a result of neurological deficiency secondary to the peripheral neuropathic disease, then there's going to be reduced innervation of the arteries and arterioles, therefore they will simply relax. So the blood supply to the feet can actually be pathologically high with full and bounding pulses. So very often the feet are very warm in patients with peripheral neuropathy. High arches with possible clawing of the toes are clinical features of motor neuropathy. So if there's no innervation or inadequate innervation of the muscles in the foot, then the arches can become high and the toes can become clawed. And this is a problem because it means the metatarsal heads are often rubbing on the shoes. So that is a feature of motor neuropathy. But an ulcer which is not very painful, of course, is going to be a clinical feature of sensory neuropathy because the patients are unable to feel their feet due to the peripheral sensory nerves having died as a result of the peripheral sensory neuropathic disease. Now, sensory ulcers particularly often occur on the plantar area of the foot or on the side of the toes. Now, the top of the foot is the dorsal surface and the bottom of the foot is the plantar surface. And there's pressure effects with the weight of the body on the plantar surface and also pressure from shoes if they don't fit very well on the sides of the toes. And if there's pressure, over time that can compress the capillaries and that will reduce the blood supply to an area of the foot. And over time, if you reduce the blood supply, the tissues can be no longer viable and you'll get small areas of necrosis. In effect, small pressure sores. And this can be compounded in diabetes because there can be the development of hard callus. And the hard callus will press on the soft tissues underneath, compressing the capillaries. And a small area of tissue will die. And then infection can develop underneath the callus, which can track to the bones, leading to osteomyelitis. Now, in you or I, if we had an infection tracking to our bones, it would cause extreme pain. But of course, in diabetes, very often they don't feel the pain because of the peripheral sensory neuropathy. So ulcers often occur on the plantar area of the foot or on the side of the foot. Now, if you're working in tissue viability, you're going to come across malignant ulcers. So which of the following statements are true of malignant ulcers? And we're looking for 4 answers here. Well, it's wrong to say that malignant skin tumours never metastasize. They can. And existing skin tumours may ulcerate. Arterial ulcers and venous ulcers being etiological in breast cancer is just, well, that's nonsensical. Malignant ulcers are fairly rare, and an existing ulcer can become malignant. So anytime there's long-term inflammatory changes, long-term inflammation can lead to malignant change. So existing ulcers can become malignant. So especially in a long-term ulcer, if it's not healing, it's always worth considering the possibility that there is malignancy within the ulcer. Well, tropical ulcers cause a huge burden of morbidity, especially in poorer tropical areas. So what are the aetiological factors that you know of in tropical ulcers? Well, when it's very hot, there can be blockage of the sweat ducts, resulting in prickly heat. But it's not an aetiological factor in tropical ulcers. And malaria is very common in tropical areas and can cause a lot of suffering, and it often causes death, tragically. But it's not an aetiological factor for tropical ulcers. And ultraviolet radiation, especially in light-skinned people, can lead to malignant melanoma. But it's not really a aetiological factor in tropical ulcers. But local injury can be, because the local injuries often become infected. And insect bites are most commonly the cause of tropical ulcers, because the insect bites become infected. And there's ongoing bacterial infection, often caused by fusiform bacteria. So the main pathological process in tropical ulceration is ongoing infection with these bacteria. So let's go for 3 more facts about tropical ulcers. Which ones are you going to choose? Now, tropical ulcers often do begin as a painful papule or blister. Now, a blister has got obvious fluid. So it's fluid in the upper layers of the skin. That's what a blister is, an area of fluid. But a papule is a solid elevation with no obvious fluid. And it's a circumscribed area, anything from the size of a pinhead to about 1 centimetre. If it was larger than 1 centimetre, I think we'd call it a nodule. And if you get a cluster of papules together, then that would be a papular rash. They can be different colours, purple, pink, reddish colours. But the trouble is when they get scratched, that opens them and they become infected. And it's the same with blisters. Once the top of the blister is opened, very often infection can get in and the infection can become established. Now, tropical ulcers are painful, so it's wrong to say that pain is very rarely reported. That would apply to diabetic sensory ulcers, but tropical ulcers, part of the reason they have such an ongoing burden of morbidity is that they are naggingly painful. The pain is usually continuous, and they often become fibrosed, partly healed, and that's why they're often so difficult to get rid of, to eradicate. And while deficiencies of various nutrients are common in many poorer areas, tropical ulcers are not always caused by dietary deficiency. Although it's true to say that anyone who's malnourished is going to be more prone to infection, therefore more prone to developing tropical ulcers if they are malnourished. Well, this is just a quick question about the epidemiology of leg ulcers. So in the UK, as with most Western countries, venous are the most common, then arterial, then rheumatoid, then diabetic. If you look at the population as a whole, this is what we find. Now, traumatic wounds can become chronic, resulting in ulceration. So which of the following statements are true of traumatic ulcers? Well, it's true that traumatic ulcers often begin with some localised trauma to the gaiter area. Repeatedly, patients will come to us and say, well, I just knocked it on the edge of the table, or I just knocked it on the step, but it didn't get better. And this is usually because there's some underlying venous insufficiency or arterial disease. So I'm sure you're knocking your legs all the time, sustaining minor injuries from time to time, but they heal up quite effectively. And if you've got vascular compromise, whether it's arterial supply or venous drainage, then the ulcers are much more likely to develop. Well, if any injury, such as a fracture, leads to damage of the veins, this can lead to chronic venous insufficiency syndrome. So fractured leg bones could do this, as could other types of injury. It's wrong to say that burns will never lead to ulceration. Trauma to the chest or abdomen may cause leg ulcers for an unknown reason. That's wrong. And the mechanism of ulcer perpetuation after trauma is primarily psychosomatic is wrong. Psycho is mind, soma is body. Psychosomatic is where the mind is affecting the body. So it's wrong to say that this is a psychosomatic condition. Well, if you've got this far, well done. This is the last question in this series, and it's about rheumatoid ulcers. So choose 3 answers which are very probably significant in the etiology of rheumatic ulceration. Well, patients with rheumatoid disease no more likely or less likely to eat more or less fruit than the rest of us. Local vasculitis is a factor. So the rheumatoid disease causes inflammation, and it can cause inflammation of the blood vessels, reducing the efficiency of those blood vessels. Poor venous return due to reduced ankle joint mobility is another factor, because rheumatoid disease often expresses itself as rheumatoid arthritis, affecting the joints. And there can be debilitating effects of long-term steroid therapy on the skin, because patients with rheumatoid arthritis particularly often take steroids for long periods of time. Heat treatments aren't really going to be a factor, and I don't know of any common genetic factor in the etiology of ulcers and rheumatoid disease, other than that the rheumatoid disease predisposes to the ulceration.